Good morning. Welcome to this meeting of the Health and Welfare Committee. My name is Tina Sablan. I'm the chair of this committee, and today is July 28th, 2022, and it is 9:00 a.m. Present today from the committee, we have our vice chair, Leila Staffler, and members, representatives Sheila Babalta and Donald Manglonia. Representative BJ Attal may be joining us shortly. And also staffing the committee today, our legislative assistant, Claire Sablan, legal counsel, Brendan Lade. Welcome, Representative BJ Attal. Thank you for joining us. And John Diaz is our IT guy. And I'd like to also welcome our representatives from the CNMI Medicaid agency. The purpose of today's meeting, colleagues, is to receive updates and this briefing from Medicaid on the status of their funding requirements for the CNMI local match, concerns that have been raised regarding presumptive eligibility and how that may be impacted by concerns about the local match and the end of and within 3 months or whenever of the public health emergency and how that will affect enrollment here. And I guess without further ado, I'd like to call this meeting to order and ask for a motion to adopt the agenda. Motion has been made and seconded. All in favor of adopting today's agenda, please say aye.
Aye.
All opposed, please say nay. Motion carries. Today's agenda is now adopted. I'd like to ask that we defer item C of our agenda, adoption of meeting minutes for our next meeting. There was a concern that we may have just missed the 72-hour requirement for calling our meetings of the Health and Welfare Committee. So just out of an abundance of caution, I'd like to not take action on that item and just move to the public comment section. Is there anyone from the gallery who would like to make public comments before we go into our Medicaid briefing? And seeing none, let's invite Ms. Vicenta Borja, who is the acting director for the CNMI Medicaid agency, and Annie Regis, our program integrity and compliance manager. Thank you and welcome, Ms. Borja and Ms. Regis. Ms. Borja, I'd like to just open the floor to you now to provide your updates for this committee, and then we can go into question and answer.
First of all, good morning, Representative Tina and members. I am here today to address the local match requirement and other concerns you may have. I would like to start off by discussing Public Law 2208 fiscal year 2022 budget, because we were only appropriated $380,000 for reimbursement purposes. Because an assumption was made that the ARPA appropriation were allowed to supplement the local matching requirement. However, I discovered that there was an interim rule in the Department of Treasury, 31 CFR Part 35. Item C, other restrictions on use, payments from the fiscal recovery funds may not be used to satisfy the state share of Medicaid. In order for us to maximize the over 100 million federal allotments that were set to expire this September 30, we would have needed an additional 7.2 million from the general fund to match. However, due to timing, we may not need the entire amount anymore. I just hope that we receive enough matching to at least exhaust the 1108 funding, which is the bulk of our federal allotments. As of yesterday, we still have about $28 million of the 62 million available. I have had discussions with the administration and the Senate in regards to this issue and was informed we will be meeting soon. However, I welcome other options, ideas, or solutions you may have to address the needed local matching, including an idea of a reasonable amount that you may think, and I'm willing to work with at this point. Additionally, we are seeking an additional local appropriation to match the 50% needed for administration in the amount of $241,049. For the most part of the increase in administrative costs includes software upgrades and licenses in support of the Medicaid Enterprise Systems project that is not covered under the project grant. In addition, to cover salaries and benefits for the additional members of our team, as well as approve the well-deserved within grade increases that are still pending. Our current local matching needs for the current fiscal year is the most critical and time sensitive, so I'd like to address this first and foremost, then move on to other issues you would like to address. Thank you.
Thank you, Ms. Borja. Ms. Regis, did you want to add to that?
Not at the moment. It's just with regards to the local match for the 10% on our own project, which will be somewhere and roughly at about 800 and some thousand.
Okay.
Sorry, can I add? We're just talking
Sure.
about FY22.
Oh, 22. I'm sorry.
Yeah, she's talking
for
about FY23.
Okay.
Yeah.
What I just mentioned is in regards to this fiscal year.
Just for this fiscal year.
For now.
Okay. Could you run us through those numbers one more time?
Okay, so initially we needed $7.2 million, but because we are already towards the end of the fourth quarter and if you were to give us the additional funding in the local match, I would have to transfer out all the expenditures that were charged under ARPA funding that we were appropriated so that we can utilize the 1108 funding.
Okay. And how much is that?
Well, we were given 38 million, which is too much for us.
Okay.
We don't necessarily need all that money. A good number at the top of my head right now, and based on the timing and the expenditures that we can try to transfer out, is a roughly $5 million at the
That you would need for
least.
this fiscal year.
Correct.
Okay. And then the additional amounts that you mentioned for administrative costs, is that that's not included within that local match
It
amount?
is within
is.
the 5 million is the rough estimate for both.
Okay. And could you just help us understand what would the consequences be if we are not able to find that 5 million before the end of this fiscal year?
We will have to sacrifice the $28 million that was appropriated to us. It does not roll over, so it'll be returned to the federal.
And how much would be returned to the federal government?
Just the 1108 funding is 28 million. We
28
do have
million.
other funds, but this is the bulk of it.
Okay. Thank you. And I do see that our CEO from the Commonwealth Healthcare Corporation is here now, along with the CFO, Ms. Purley. If there are no objections from the members, we could invite them to join the panel.
No objections.
Please.
Morning, Yola.
And I guess before we move to any statements that CHCC would like to offer for the members' awareness, Ms. Borja, could you also give us an idea of the upcoming fiscal year as well, what Medicaid's needs would be?
So in the original budget submission package that I prepared early March, the numbers I gave was prior to my knowledge of the increase in cap. So prior to FY21's amendment to Section 1108, we were only capped about 67 million a year. However, that was changed to 60 million. So moving forward, our base salary our base allotment would be our previous fiscal year. So today, fiscal 22, we are at about 64 million. In FY23, we are looking a little over 64 million. That's just the 1108 funding. We have other grants.
Okay, and the local match requirement, I'm seeing for fiscal year 2023.
For FY23, I also learned the extension of the 83% FMAP expires December 13th. So that is for the first quarter of fiscal year 23. After December 13, it reverts back to original Medicaid, which is 45.55. So that would be the local share of 45%.
Wow. Okay.
Yes. If there's no act in U.S. Congress, and as of yesterday, there is no word whether there will be an extension.
Okay. So, how much would the local match be then, given that?
I did a rough estimate since our numbers are not yet confirmed as far as our total funding, but reimbursement is an estimated 26.6 million for the local in order for us to utilize our federal funds.
26 million?
26 million.
Okay. Thank you. Yeah. Well, thank you for that update. Colleagues, at this point, do you have any questions for CNMI Medicaid agency? Representative Maglonia.
Thank you, Madam Chair. Have you spoken with finance to convert some of the ARPA into general fund by by having them use general fund and then backfilling
Yes,
it with?
I did have a meeting with Secretary of Finance as well. I've been in constant communication with the Senate committee. They have informed me that they are identifying. I have also been in communication with their fiscal analyst to give them a little bit more reasonable amount. The 5 million that I mentioned earlier, that was pretty much the same amount that Secretary and I have agreed that we can at least work around to ensure that at least the 1108 funding is exhausted. I did mention to them and included in a letter that I provided that I am willing to give back the CNMI government the 30 million in ARPA. The only reason why I would like to keep the $8 million is because in FY20, because of the COVID pandemic, there were a lot of setbacks in operations. I mean, in other words, processing claims for our providers. So with our federal funds, we cannot pay for claims older than 2 years. So we are taking advantage of the ARPA funds to pay our providers for older claims that are unpayable.
Okay, but you still have the 38 million.
We still have the
With you
38
guys.
million. We have exhausted it. We are about 1 million or maybe less at this point. If we are given the local matching, we will transfer those charges into our 1108 funding.
Sorry, so of the 38 million, you have about a little over 1 million left,
Correct.
but you need to convert all that into
Correct.
local funding. Okay, thank you.
Thank you. Colleagues, any other questions? Representative Vata.
Thank you, Madam Chair. Ms. Vora, you mentioned, so the $30 million should be returning back to the central government?
Yes.
So for FY22, you need $5 million to do
Yes.
by September 30.
Well, it's more like as soon as possible because we need to identify these things and then transfer it and also process the drawdown, work with finance, treasury, and ensuring those are all done before September 30.
Okay, and so Medicaid, I guess the grantor agencies are following our fiscal year budget.
Correct.
They're not running on a calendar
Mm-mm.
year budget. And so the Secretary of Finance, through their fiscal analysts, they're able to identify the local funds that they will
I'm
be
sorry,
transferring.
Senate or Mr. Demapan, the House fiscal analyst, not
Oh.
Secretary of Finance fiscal
Okay.
analyst.
For the current fiscal year.
Current and next fiscal year, yes.
Okay, so for the current fiscal year, they've already have something broken down as to,
I have provided them some numbers. They are still trying to identify and come up with a solution to that current request that I'm asking for the local.
okay. So they haven't gone back to you guys in
Not yet.
regards to that? How about the Department of Finance? Have they gone back to you guys in regards to reprogramming of the $5 million to assist Medicaid right now?
Not yet.
Not yet? Have they given you a date that they might be able to?
I am supposed to be, I am waiting for a meeting with Senator Vinny Sablan. He is, and I'm sorry, King Neighbors, who's also included in the conversation, along with Mr. Damapan. So they are aware of our situation, and I was assured that we will be meeting soon.
Okay. And when did you guys meet?
Oh, Miss with Vinny Sablan, it was all through messaging and email.
Okay.
With Secretary of Finance, I met with him a few weeks ago, or a couple weeks ago.
Okay. Yeah. We need to. I think we need to understand that when when we're working with the numbers and we're trying to move monies, it's kind of difficult for them to initiate it. They can't initiate the budget process. They can't initiate amending the budget. And I think maybe we should, I guess, through our chair Ways and Means, it's important for them to at least be in the conversation, because if we're finding this out right now, and it's very difficult now to go back to 22 if we don't have the true numbers or the audited numbers for this current fiscal year, because the audited numbers for 2021 just came out in June. So I mean, unless they're putting the money into deficit reduction, we can actually encumber those monies to address this issue. You know what I mean?
Understood, but I'm not sure exactly how they plan to proceed.
Sure. And then the WGI that you had mentioned earlier, what's the amount that's owed to you guys?
Oh, I did not come up with that figure. I still have about 6
Employees.
employees who are waiting for that
And when is their anniversary? Or
since April.
so they have not received
Have
it.
not received the WGI.
And these individuals are locally funded individuals?
We are at a 50-50 match.
50-50?
Yes.
And so the ARPA monies that were used for the previous WGIs, those guys received their WGIs?
We never use ARPA money for our administration as far as salaries.
Oh,
We've
well,
only been we were appropriated a little over $10,000 in ARPA for administration, but because of our with the munis issue in the early on in the fiscal year, we weren't able to establish our account, so we had to use that to pay our power.
okay. But the monies were transferred, the $10 million was supposed to address the WGIs.
Not 10 million, 10,000.
I mean, sorry, 10,000.
No, not at all.
Not
It
all?
was utilized at the early part of the fiscal year, which was back in October.
Okay. So maybe we can get the individuals after this meeting that are owed their WGIs, because right now they're using ARPA to pay for WGIs from the central government. I think it's important that we get those individuals their WGIs, and it should be retroactive to April.
Yes. sir.
So if we can get that information, I think that's important. Without your staff, you're not really
Of
going to get
course,
anything,
yeah.
right? So, okay, so 2023, you're looking at $26 million that's needed.
That's if there's no act in U.S. Congress. And as of today, there is nothing.
Well, yeah, we can't really base
We
ourselves
cannot,
with US.
so this is the worst case scenario.
Yeah, and their fiscal year it's not the same as our fiscal year. Their fiscal year runs throughout the year.
Yeah.
Various different programs have different limitations within the fiscal year, different appropriations within the fiscal year. And the difference with U.S. Congress, obviously, and our legislatures, they can print their own money, and we can't, right? We stick to whatever we appropriate by September 30, and whatever extra monies that should have been identified to the legislature, that's the monies we can reappropriate or appropriate back into the budget. So, well, I guess we're gonna have to work with you on finding the money in the next couple of weeks. Thank you, Madam Chair.
Thank you, Rep. Atal. I wanted to at this time ask if our representatives from CHCC had any comments or considerations that they'd like to bring to our attention. Thank you.
Thank you, Madam Chair. I'm going to put on my hospital hat first. So for the hospital side, this 55-45 is going to affect us a lot. We have been getting 83% of our funding, and we are using the certified public expenditure methodology for payment. And that has been really, really helpful for the program itself, right? And also for the CNMI. So, I'll go ahead. You want to go ahead? I'll go ahead. Right now, for example, with the 17% FMAP, there is about $5.6 million that we often have to wash off, right? And that's because of the certified public expenditure. We just basically put that as our share. But then we have also, if it does go back to 55-45, with our current expenses of, what's the total? Sorry, I didn't get the total here, but it is basically the matching for 55-45 would be $17.8 million. So we are going, as Ms. Borja mentioned, we're talking about $11 million of a loss for the hospital side if we do go back to the 55-45. And, there's just no way we can, especially with a lot of eligibles from the presumptive eligibility, which, eventually the program, which they're talking about administrative services, they're going to have to determine who are really eligible for the Medicaid eventually when it expires. And there's going to be some, actually probably even most, who are probably not eligible, and they will be removed from the program. So there is a big impact, a large impact for this community. So I'm going to go put on my CHC health official hat, and a lot of discussions, and it's a mix of CHC hospital as well, is the referral system. We have been utilizing the Medicaid program to pay for medical claims, which has been a problem in the previous management, I guess, if you want to call it. It's just a matter of letter of agreements and contractors. We are recently signing with GMH, which we have lost agreements with GMH for many years already. So we're working on that. We're working with UCLA. We're working with some providers, but we have a problem when it comes to pharmacy, for example, and dialysis. Pharmacy off island is, they expect them to be electronic, and they're not, and so they need the support for electronic system. When we see what happens in anywhere else in the U.S. where people just enroll and get a Medicaid card, claims are getting processed electronically. We are really, they need help. They really do need help. And if I'm not mistaken, it's a 90-10, or is it a 90-10? 10%. That's all we're asking for these guys, this agency to be funded. We should be taking advantage of that. We should have been taking advantage of the 83-17%. It's about to expire. I'm hoping for a continuing resolution so that can be extended. But, we don't know what's happening right in U.S. Congress. So, that is a significant impact. What happens to them affects them, affects us, because again, the patients we're sending off island, they want to work with us. They want to say, hey, yeah, we want to sign an agreement, but they don't want to deal with paper billing. They just don't. This is a day of age where it's like, why we're even talking about paper billing, but it is, they need the support. They have an IT group, workers that are actually from us. But I've not, I don't have any grudges, but it does happen, But at the same time, they're really working hard to try to get their system up and running to be at least even compatible to what's happening in the U.S. So we do have we have an opportunity to use the funding from Medicaid. We haven't. There's times when we have to say, unfortunately, we have to use local funds because the pharmacy will not accept Medicaid. We have providers, for example, in Guam that do not accept Medicaid. And so these are things that we want to try to expand, but it's hard when there's challenges and they cannot meet the match for that. Again, a loss for CHCC as a hospital, a loss for the program itself. You're going to have to find some money. If we don't use Medicaid, you're going to have to find some money to replace the funding that we're going to have to use local funds to pay for the claims that are going off island. And we can't put that under the CPE because that's not us providing the services. So anyway, CFO, did you want to?
And I'm putting on my math hat here. 5 million versus 31 million. what they're asking for the local government to find 5 million so that they can return the ARPA money, and the ARPA money can be used for other operating expenditure. It's it seems like it should be an instant find that 5 million so that we can get back the 3 million to reprogram for other needs like the hospital. and then and then to bring some background on why the hospital providers that are partners with medical referral are not um, willing to enter into an agreement with Medicaid is the lack of local match. So in the past there were historical delays in payments. So because of those delays, the hospital providers, they don't want to accept our Medicaid because our local match, they cannot use the federal money if the government will not fork out the local match. What became the remedy was the medical referral paid 100% coming out of local funds. Did that even make sense? We should have provided Medicaid money to timely pay the providers so that relationship with providers would not be damaged. We are rebuilding relationship right now with almost 9 months administering the medical referral program. What the CEO and our team is trying to do is rebuild relationship. But until the Medicaid program, local match is supported, the same problem will arise. So we are here to support Medicaid so that we address the other issues that are related to it.
Wow, thank you for that. And since we are on the subject of medical referral, could you give us an update on I guess how the transition has been going, and do you have any numbers you can share with us now in terms of the difference that it's made to work more closely with Medicaid and to ensure that local funds aren't being used to pay for referrals when Medicaid is available? What does that look like now?
All right. Gosh, there's been a lot of changes, and a lot of unpacking. And uh, we're already working with a travel no transportation system in the U.S. In trying to make sure that even like what happens now is Hawaii office would arrange the trips, and we're trying to basically have just an account where the patients can just easily call Yellow Cab, for example, and not have to worry about waiting for someone to do that for them. So we're working on those things. We are we are emphasizing the need to be accountable, especially on the need of making sure that this really is a patient, and making sure that the services are being provided specifically for this patient. Going back to the Medicaid program, even if Medicaid, for example, because they pay for transportation, if they're eligible, of course, if they're Medicaid eligible. In the US, Medicaid ground transportation is covered. So even if we're trying to arrange that here, with the program here, and say, okay, we have to have them sign up, they need an agreement. Again, those are things that needs to be in place, making sure you're doing due diligence in your reviewing of transactions. And so we want to make sure that things are in place. And it's and it hits a snag here and there because of we're requiring, for example, the vendor to provide us a more detailed report showing where this patient went, right? And it's unfortunate that it took months for that vendor to actually provide it to us. So we're paying the vendor, but we are also moving on to a cheaper, a more cost-effective, if you want to call it, basically a cost-effective transportation system. We're also looking at reducing some of the rentals that we're paying for a lot of empty rooms, expensive empty rooms, and so. we're trying to, especially since we use the USC Keck hospital medical system, we are trying to basically just get the hotel across the street, rather than, getting them to a transportation that will cost $120 one way, just for the patient to be transported back and forth for their trip. So it's a lot of things that we're shaping. Basically, began because we are addressing the audit. The audit report gave us details of what were the challenges and the findings, and putting them into policies and procedures, making sure that they go through the accounting system, following gap principles. Those things have to be done, and it does kind of delay the shifting, right? Because of that previous history of that's the operations before. So we have minimized, for example, the use of impress funds. The impress funds are focusing on things that need for operations, but not for vendors. Like, those things need to be really reviewed and reconciled before we actually pay them. So those are things that we're fixing. And going back to the Medicaid, we're trying to get an agreement with UCLA system. We have a good relationship with UCSD, but then we may need to put an agreement with them as well. And so those are things that we're just kind of building because of our providers at CHEC that have a relationship with the providers there. And also going back to Hawaii, we're also looking at, why are we not using Hawaii as often as we're supposed to use? Because the regulation says Hawaii is your last stop. So why are we going beyond that? We want to go beyond that for emergency reasons, but we need to show that we are actually looking at Hawaii, and that's something that we have the support there. It's hard to manage operations away where you don't have an office, and that's been the challenge always with, and yet you've brought up some situations about San Diego and Los Angeles, and it's hard, and it without that, especially with the time zone difference. So we're gonna try to rebuild the relationships with Hawaii. There is no relationship with Hawaii right now, so we need to figure out what can we do about that.
And
Yeah.
I'm sorry, just to clarify, you say the regulations say Hawaii is the last stop. What
Mhm.
regulations are
The
those?
medical referral regulations,
Med-
and also their state plan actually requires that the contractors are really with Hawaii and Guam, and then anything beyond that is an LOA, right? Is it the
We actually have contracts with Rady Children's Hospital, which is in California, and
oh, okay, just for correction, except for kids, it's in the state plan, it's in the medical referral, except for kids is Rady's, yeah. So that's why.
we actually have an agreement with Good Samaritan that has been in place since 2014.
Okay, yeah.
Yeah, a while
Yeah,
back.
we're not using Good Samaritan as much.
Yeah.
Yeah, so.
Okay.
It's
So,
also
yeah.
dependent, it's also dependent on the provider themselves, if they would like to become a Medicaid provider and sign an agreement with us.
Okay.
So like what they had mentioned, as Ms. Munya, is it's a letter of agreement signed often based on whatever rates that they would come up with and however Medicaid can pay. But if we want to establish the relationship with our mainland providers, they would have to sign an agreement with us rather than going through that LOA process. And
Actually,
adding
sorry.
to it,
We actually don't have to have a provider agreement with the stateside providers. According to our state plan, we rely on their enrollment with their state. So, for example, Medi-Cal, which is the state of California, Medicaid. The only time an LOA is executed is if there's a negotiation in the rates. Because of the challenges of finding, providers who are willing to service our off-island beneficiaries, sometimes we have to just give them what they want in order for our patients to be seen.
Okay.
So going back to not the state plan, the regulation does say Hawaii.
Okay.
So we're hoping that bill that you have for referral will basically open that. But if we have to be also mindful that, again, going back to the audit findings, is that we're not following regulations. So we need to follow regulations,
I
right?
see.
Okay,
Well,
thanks.
yeah, and I think there was also some question about, well, are you working on promulgating new regulations?
Not, it's my understanding that we shouldn't and we couldn't do that because of the fact that the funding for, or the delegation from me to be the expenditure authority is, right now at this point, I would rather wait for the bill to
bill.
basically give me full authority rather than just an expenditure authority.
Okay. So since the beginning of this transition of medical referral to CHC, and since you did become the expenditure authority, and now that Medicaid is more involved in paying for medical referral services, do you have a figure? How much has Medicaid actually paid since the transition began for medical referral services?
I don't. I wouldn't. I guess because we don't see those claims because they were going directly to them.
Just for the top of my head, I can remember paying USC Keck for one batch of claims over $1 million. Just that's just maybe 5 patients.
Mm-hmm.
It's really costly.
Okay. Yeah, I guess I'm interested in seeing what the difference has been, because I think Miss Helen Sablon did provide us with some data about what Medicaid has paid in the past for medical referral, but she said even then, like last year,
Well,
that there was that Medicaid could have been paying for
yeah,
more.
since they've taken over Medicare referral, I must say
Yeah.
that our expenditures have increased because of the expansion of other options for other providers that they
Mhm.
have communicated and built relationships with. And so as long as we are following, we will pay.
Okay.
Yeah. She's been keeping me busy.
Okay.
But again, going back to this is really important too, is because they removed the cap, right? They removed the cap and they rebased it, and
They increased the cap.
Oh, sorry. They did not remove the cap. Correct. They did not remove the cap. They increased the FMAP. I'm sorry, the amount, the funding, but it's based on previous year's expenses. And so, right? Previous year funding. Right. So, but it's based on expenses, isn't it? That's what the letter said. It says expenses. She's shaking her head. Yes.
Oh no.
We're disagreeing here. Nevertheless, it's I guess what I'm trying to say is that if we weren't spending it, then we're not going to get the increase, right? I mean, you're basically basing it on that. You look at, for example, and then maybe this is my only theory. I mean, looking at, for example, American Samoa has a higher funding than we did, right? American Samoa has higher funding than we did. That's correct. How is that? Because they pay for everything that goes off island. They go send them to Hawaii. We were using medical referral funds, and medical referral funds is not Medicaid. And so obviously this is one way to save the money from the local part and
Yeah.
give it to and she spanked me. So
No, I just wanna enlighten on the keg example that Miss Tenta mentioned, that she paid about close to $1 million for 5 patients. That would have been $1 million under medical referral, 100% local.
Yeah.
The fact that it was paid by Medicaid, it was 83% federal and 17% local. Especially if we find the 5 million they need, 28 million will be paid by federal, and we will just pay 5.
Yeah.
So it does make sense to use Medicaid versus medical referral. If we could make a lot more people qualify as emergency Medicaid rather than making medical referral pay 100% of a 1 million bill.
Yeah, I mean, that makes perfect sense. Thank you. And Miss Munoz.
just one more thing. This when you put money in as a state plan, if you put more money into the Medicaid program, there's a lot of things that we, as going back to being the health official, there's a lot of things that they could pay for that could not be covered, or like, for example, we're talking about, she mentioned about presumptive eligibility. We were talking about the breast and cervical cancer program, right? Sorry, yeah, she, there's an opportunity. There's a lot of things that has been changed, has been given directly from the White House, saying that this is something that you could take up an opportunity using the state plan amendment or 1115 waiver, whichever it was, SPA. To change the plan and cover more people and cover more services. But as we talk, we have this discussion with Tenta, and her worries, and she's rightfully right to be worried, is, well, how am I supposed to match it? And that's one of the reasons why we kind of, we would love to look at, what else can the program really expand on. There's mental health services, there's prevention plans that you could actually incorporate into this community, but because of the matching situation, it's hard for them to submit it over to Region 9 and get approved and say, oh yeah, let's approve this state plan. Their answer to her would be, you cannot even match. So why bother? So anyway, did I say that right? Okay, now this time she's shaking.
Thank you. Sure, go ahead, Ms.
Sorry,
Curley.
we talked too
Yeah.
much. And looking back in 2019, when the FMAP was 100%, medical referral deficit was 18 million. That could have been federal match 100%.
Wow. Thank you.
Retrospect 2020.
Can I ask, so of the money that was allocated through ARPA and through the general fund for medical referral, how much has been exhausted to date?
We'll come up with an expenditure, and we want to do that for this year. In fact, we're trying to collect as much data, and we will present it to this body. But there's there's also the issue about, for example, the travel, right? Like, we're paying for all these tickets, and most of the patients, if I'm not mistaken, about 90% of our patients are Medicaid, whether PE or just regular Medicaid, and we are paying that up front. We're paying for example, ambulance transfers are $200,000. Do you pay that 100%? 100% from all federal?
100%. Oh, no.
No, right? See, so so when we're processing all these transfers, we have a lot of costs. Most of our costs are from transportation, lodging, and subsistence. We want to, for example, mirror, and this discussion, with her, is that, we want to mirror, for example, American Samoa or U.S. Virgin Islands state plan. They cover subsistence, they cover lodging and accommodations. So, but bringing it again to their attention will be a flat no, because how am I supposed to do that if I can't match? But again, it's 83% right now. Again, of course, it's going to go back to 55 if there's no continuing resolution in December. That then we're back to 55-45. But nevertheless, there's a lot of things that could have been paid, and we're going to be we're going to be actually be billing them. So we're going to be sending them a chunk of bills for Medicaid patients to reimburse us for the travel, for the airline tickets, but she's going to have to find the 17%. That's the problem,
I
which is,
see.
yeah.
So CHCC is fronting the costs for transportation, lodging, and subsistence, and then getting reimbursed for a portion of those costs. Is that how that works?
They need to pay 100%. They can't, for transportation, they need to pay 100%. They can't put that right now as
Okay.
part of their part of the CPE. So
Okay.
they have to find the 17% before they pay us anything.
Got it. Okay. Thank you. Colleagues, at this point, any questions for our panelists? Representative Mangorian.
Yeah, this is actually for Medicaid. The Ways and Means Committee is in the process of removing all vacant FTEs, whether they're funded or unfunded. And we came across Medicaid, and there are close to 25 positions that weren't filled. There's about 11 Medicaid Enterprise Systems and Health Information Technology positions, and about 14 under the Medicaid. Are any of those positions filled to date?
For the 1980 FTEs, the Medicaid Agency Administration, we have fulfilled. As a matter of fact, we exceeded by one. We had no choice but to place that person under the project, which is the Medicaid Enterprise Systems, and Andy can speak in regards to the open or unfilled positions.
So we currently have, as what Ms. Munya had mentioned, we do have some 2 IT personnel that's currently in-house and staffed by the university. I know we were talking about that whole Medicaid personnel MES bill, which we'll be discussing at a later point in time. We do plan to fill those positions. We're currently under the submission of the grant award and getting the blessings from CMS to get those funds available at 9010. So we would like to still keep those positions that are currently vacant and available for the fiscal year for hiring. If
But
possible.
of the 25, how many have you filled already?
It's only one, which is me.
I'm sorry,
I
you
mean,
need to
and
separate the two
for
because
the
they're different
admin. Yeah. So there's
sections.
Right.
So there's administration, which has been fully filled, which is the 14 personnel, 15.
It's 15.
And then one with compliance.
We exceeded by one.
Yeah, one with compliance, which is now with my the MES program, and then myself. The rest are still vacant, which needs to be filled. And we're awaiting for funding on that one as well for the next fiscal year. So if we could still keep that, we would greatly appreciate it.
Thank you.
Thank you. Any other questions from the members? Since we are on the subject of the MES recruitment and retention bill, that would be now refiled as House Bill 22-100. I know we said that we would have a more extended conversation later, but I wanted to ask, have you had any other meetings since this bill was vetoed with OPM? To resolve some of their issues that the Attorney General's office raised with the first bill that we passed that was vetoed.
No, I've never discussed anything with OPM as far as the original bill that was vetoed.
Okay.
No.
Okay, and nothing since the second bill, House Bill 22-100 was
The
reintroduced?
second bill, I did meet with the director of OPM, only because I was never involved in the original drafting of either the first bill or the current.
Mhm.
And so I wanted to spend a little bit more time understanding it before I make any comments as the acting director.
Okay. And then the status of the MES is that, did you have anything else you wanted to add to that, Annie? Besides that you have most of these positions still vacant and you're still actively recruiting?
We're currently reshuffling the position descriptions to reflect the actual positions that we would need for this coming fiscal year to help support our health information exchange or MES, the MMIS system, and together with the decision support system, so the data warehouse. So all of that will come forth at a later point in time. We're going to make an update to our budget. What do you call that? Position request.
Okay. Thank you. Any other questions from the members? Representative Abato.
Thank you, Chair. Good morning. First of all, thank you so much for being here, for the work that you do, and for helping me understand like the situation in, layman's terms. I feel like we're in crisis mode and everyone's like pretty calm, but I want to, I just can't believe it. I am shocked, that we need to find $5 million ASAP. In order to keep the $28 million and not return that to the federal government. And you did mention that would be one of the consequences, but can you help me understand what that would look like if we don't find the 5 million and we must return the 28? Will that look like vendors not being reimbursed, patients not being seen?
Well, we are close to depleting the ARPA funding, so I would have to stop paying our providers. That's the bottom line.
Okay.
If we don't get the support for FY23 local matching, we may have to shut down some services and cut off a lot of the programs that we implemented during the public health emergency that we have temporary authority, including the presumptive eligibility. We may have to end it before the public health emergency ends. These are choices that we have to make in,
Right.
or, unless we go on a deficit.
Right. Okay. And who else have you spoken to about this situation? Can you just give me an idea of who else is a part of this conversation? Have any ideas been floated around of what pots of funding are available, just so that we can?
Well, I
use that
only
information?
assumed the acting position in mid-April, since Helen Sablan left in February. So since I assumed the position, I wanted to prioritize this. So I did my internal research as far as what we need and what we need to do. So I reached out to the Saipan Northern Ireland delegation. I was advised to inform the administration as well as Secretary of Finance, and so I did that as well. But that was um, a while back, maybe May, if I'm not
Mhm.
mistaken. So we have been in active communication with the Senate. I am providing them as much information as they request, but I have not received any solutions.
Right.
So I
Right.
don't know.
Yeah, thank you. I guess my mind is already thinking about what funding sources are available, what pots, should we look into, compact impact funding? I mean, I don't, at this point in time, if we need to get this, like she mentioned, out before September 30, then we need to start putting our heads together and finding the $5 million. So thank you for being here and for just bringing it to the forefront of our minds and our conversation here in the Health Committee. Thank you, Chair.
Thank you, Rep. Babata. And I guess just following up on that, what would the impact of having to return $28 million look like for CHC?
I'm gonna beg her not to do that. Well, obviously, if she returns that money, then it does become questionable in a lot of the state plan suggestions that we're trying to make with them. Yeah. Yeah.
Well, besides that, actually, we will continue to pay CHCC for the CPE portion because we don't have to pay them the local match. However, what the people who will be impacted by this are not only our residents seeking healthcare, is especially our patients who are off island for medical referral. They are gonna be the ones who suffer the most in this situation.
May I add also,
Sure.
since
I'm
CHCC
sorry, could
has
you
been,
turn on your mic?
oh,
Or is it on? Oh,
it's
okay.
turned on.
Thank you.
If I can add also, because CHCC is also trying to build the relationships with our off-island providers. It's the same thing with us, right? So like what Ms. Esther Munya had mentioned, if we don't have our local match, that affects theirs as well, their operations. If we cannot pay our off-island providers, who else will take them is a concern. Rebuilding that trust back and then breaking it all over again, it's not helpful for our CNMI people.
Thank you. Sure. Ms. Purley, go ahead.
And then if the program if they stop services with private clinics, those patients will all go to CHCC. And our backlog with
Yeah.
patients, our wait list is already long as it is. and the private clinics are helping in a way, right? So, but if Medicaid stops services with private clinic, they could only send patients to us because they don't need to match. They just need to pay our 55% of our cost. That's gonna kill us. The more patient we see at 55, getting reimbursed only at 55 cents to a dollar spent on that patient,
Yeah.
that is gonna affect us adversely.
Basically,
Right, right. Can we talk about presumptive eligibility now? You mentioned that Medicaid may have to cut presumptive eligibility even before the public health emergency. Could you just could you elaborate on that and also give us some updates on what your enrollment looks like now and how you expect that will change if you when presumptive eligibility ends?
Our estimated presumptive eligibility population for the entire CNMI is about 24,000 individuals. These 24,000 individuals, if we do not get the local matching and we're unable to reimburse our providers for these services, I will have to make the hardest decision and end it. It's either that or again run into a deficit if you will allow me to. There's no other option.
Yeah. And prior to presumptive eligibility, your enrollment was about 16,000. Is that correct?
um, Rough estimate for our regular Medicaid. I'm sorry.
For
Yeah,
regular Medicaid?
14,000.
14,000. Okay, so we're looking at potentially 10,000 people being removed from the rolls if they're found to not be eligible.
Yeah. Yes.
Wow. Okay. And then that would just compound the burden on CHC as well, right? Because then it would be uncompensated care if those 10,000 people need
I don't know
health
which
care
one.
services.
you haven't heard us use that word for a long time because of presumptive eligibility. Yeah, but yes, it will impact. We found individuals using the system more, better access, of course. If you remove the funding issue, they're showing up.
Wow. Well, thank you. This is all very sobering information, but so important, and I'm glad that we're having this discussion now. And I think Rep. Babalta hit the nail on the head. This is very alarming, and I would like to continue the discussion on how we find the 5 million local match that you need before the end of this fiscal year, and then also how we ensure that Medicaid is adequately funded in the next fiscal year. Sure. Rep. Maglona, go ahead.
Sorry, I'm going back to the 38 million. You said you only have 1 point or a little over a million left. Did you at least set aside 5 million from that we can convert?
We cannot use the ARPA funding for matching.
Right, but did you reserve the 5 million off the 38 at least for something that we can allocate to other agencies to take their general
I'm gonna
fund?
give you back 30 million if you give me the
I
5.
thought you said you only have 1 million left.
That's all we have right now because we are unable to utilize our federal allotments. We are running all our expenditures under the ARPA funds. But we will revert it to our federal funds and give you back the 30 million so we can utilize our federal.
So then we can take it there and just fund all other agencies. But then I think we're gonna, just to close up, I think we're gonna need to do it quickly because as we know from experience, most agencies by this time are trying to use up all their general fund monies. And so, I think that's something that we'll discuss with the committee. And with that, I yield to
Sure, Rep.
Just
Atto.
on that note, so 2023, we're looking at how many million?
2023 is roughly 26 million in local funding that
In
we need
local
to
funding.
match. Correct.
Okay, so
But sorry, that's assuming that there is no extension
Correct.
of the FMAP,
Yes.
the current FMAP.
Mhm.
right? Okay.
Okay, well, we can still put that language in the budget, right? So I'm just saying, I'm thinking we get the $5 million to Medicaid, the communication of returning the funds to the central government, the ARPA funds at $30 million, because
Mhm.
you're keeping 1 million, right?
8 million.
8 million. So we can actually cover both ends off the bat for 2023. We can find a $5 million for 2022, then use the $30 million of ARPA money to the general appropriations. That would free up about $4 million of ARPA that we can distribute elsewhere. But we can utilize the $26 million to address the central government, and we take the local funds and address the Medicaid issue, provided with the language that should the extension happens, those monies will be reverted back
Sure.
to the
Yeah.
central government for appropriation purposes, maybe to CHCC.
They
Thank you,
said
Madam
they
Chair.
don't need it.
Thank you. Any other questions for our panelists?
Just
Oh,
on that
sure.
communication, if we're submitting back the $30 million, we would appreciate that the communication from Medicaid to the Secretary of Finance, that we be CC'd on it so that we know that that money is freed up, so we include it in the 2023
Sure.
budget. Thank you.
Thank you, Roberto. If there are no other questions for our panelists, I'd like to ask that the data that you shared with us, and I think there's some additional data that we requested, if you could provide that to this committee, Ms. Borja. And at this point, are there any closing statements you like to offer the committee? Any of you? Okay. Yeah, thank you all so much, Ms. Borja, CEO Munya, Ms. Hurley, and Ms. Regis. Thank you for your presence today and for this really critical information that you've shared with us. And we will keep in touch. We do have this bill that we need to discuss further after this meeting with OPM, and I'll be reaching out to you and Ms. Regis if you're available. I know you're technically on leave, and thank you for being here today. Okay, and if there are no other questions or comments, I'd like to dismiss our panelists and thank them for their time. And let's take a very short recess. Thank you.
pen while I'm breaking anyway. Just kidding. It's at 11.
And come back from recess? Yeah. Okay, we are back from recess, and colleagues, next in our order of business, I really just wanted to share with you some very brief updates on House Bill 22-100. So I did have a meeting with the Deputy Attorney General to discuss the concerns that the Office of the Attorney General had about the previous version of the bill, and which the governor vetoed, as we know. And some of it had to do with the bill, purporting to amend parts of the statute, the code that no longer exist, that were repealed by a previous law. But there were also concerns about overstepping our authority and infringing on the authority of the Civil Service Commission. And then we discussed, possibilities for working with OPM to within existing law. So, a bill may not actually be necessary if we could work out some understanding and some agreement with between Medicaid and OPM to address Medicaid's recruitment and retention needs, especially for the MES. So I'm going to propose that we set up a meeting with OPM and with Medicaid, bring them together, and with our council to discuss, what the law already says that would allow Medicaid greater flexibility to be able to recruit and retain the critically needed technical personnel that they are required actually to hire to meet program integrity mandates. So I will keep you updated when a meeting is scheduled. We're going to look at the schedule and work that out. And of course, you are all welcome to attend that meeting. And that's it for item F. Are there any announcements under item G? Sorry, your mic. Rep.
Severability provisions. So you have two severability provisions on page 8, section 5 and 6 are one's an incomplete sentence and the other one is the full paragraph of severability. So we'll just remove that, consider it technical.
Thank you.
Before we share it.
Sure. Thank you, Rep. Atzoff, for pointing that out. We will make those technical corrections, yes, prior to that meeting with OPM and Medicaid. Any announcements from the members? Okay. At this time, may I request a motion to adjourn this meeting?
Motion to adjourn.
Motion has been made and seconded. All in favor of adjourning this meeting, please say aye.
Aye.
All opposed, please say nay.
Nay.
This meeting is adjourned, and it is now 10:15 a.m. Thank you, colleagues.
I know, sorry, that was.